Okay, and so Dr. Patrick Wagner specializes in the surgical treatment of digestive and complex abdominal tumors, including esophageal, gastric, pancreatic, liver, colorectal, and appendix cancers. He cares for patients with metastatic cancer, including liver and peritoneal metastases, as well as patients with rare tumor types such as sarcoma and neuroendocrine tumors. Dr. Wagner serves as the Director of Complex General Surgical Oncology at Allegheny Health Network Cancer Institute. He received his medical degree from Harvard and completed surgical and pathology residencies at New York Presbyterian Weill Cornell Medical Center. He also completed a fellowship in surgical oncology at the University of Pittsburgh Medical Center. Dr. Wagner is certified both by the American Board of Surgery and by the American Board of Pathology, and is a fellow of the American College of Surgeons and a member of the Society of Surgical Oncology. He prioritizes patient-centered, individualized care planning in his clinical practice and emphasizes minimally invasive approaches, including robotic surgery whenever possible. Dr. Wagner strives to make innovative treatment options available to patients with complex cancers through translational research and clinical trials. And then I'd also like to introduce Shannon Altpeter, PAC. Shannon is a dedicated surgical oncology physician assistant at Allegheny Health Network alongside Dr. Wagner, with a passion for patient-centered care and a commitment to improving health outcomes. She graduated PA school from DeSales University with her master's degree in 2011 and a doctoral degree from University of Lynchburg in 2023. With extensive experience in treating peritoneal surface malignancies, Shannon thrives in delivering comprehensive perioperative care, research, and clinical trials, and working collaboratively with a multidisciplinary team to support patient recovery and well-being. Thank you both for being here, and I'll turn it over to you guys.
Thank you for the introduction. I think my video was off, but now it's on. So I'm going to I've asked Shannon to present the trial. She did a lot of work in putting the protocol together and has been spearheading very actively recruitment for the trial. And she's kind of the face of the trial when it comes to patient care, both before and after treatment, during and after treatment. So Shannon's going to give us all a presentation, 30 to 40 minutes or so, just detailing the protocol, and then we will do the Q&A after that. So Shannon, you have the slides, I think, and you can take it from there.
Thank you. I just want to make sure I'm sharing the right screen. I had a little trouble with this.
It looks right.
Okay, great. So you're not seeing my notes.
Nope.
Okay. All right. Thank you, Alyssa. Thank you, Deborah, for that introduction. Thank you, Dr. Wagner. So let's focus on the Charlie 2 trial and increasing treatment options for patients with peritoneal carcinomatosis. So my short one-liner to the point, this is HIPEC versus PIPAC. The Charlie 2 trial is a randomized, blinded study for patients with unresectable peritoneal carcinomatosis from various cancers, including appendix, colon, and some other origins. It seeks to measure a head-to-head comparison of two different delivery methods of intraperitoneal chemotherapy with mitomycin C. So throughout this presentation, this is how I plan to define that for you. First, we're going to go over a brief introduction, just so that we're all on the same page about peritoneal carcinomatosis and treatment options. Then I'll answer all the W questions, the who, what, why, where, and when. I'm going to put an emphasis on the inclusion-exclusion criteria prior to then reviewing the full study protocol. And then we'll leave plenty of room for your questions and answers. Thank you for those who did submit questions ahead of time. I did my best to address the vast majority of them within the presentation itself. All right, so let's start by making sure we're all on the same page about peritoneal carcinomatosis. Simply put, peritoneal carcinomatosis is when cancer cells have spread to the peritoneum, which is the thin lining that covers the entire abdominopelvic cavity, including the organs within that cavity. That could be your stomach, your intestines, your liver. When cancer spreads to this lining, it can cause a range of symptoms. You might experience abdominal pain, fullness, bloating, have difficulty eating, and getting the proper nutrition that you need because of this disease. These symptoms can really impact your daily life and your overall well-being. Because peritoneal carcinomatosis can be so challenging, there's an urgent need for better treatment options. Current treatment options can fail, or they might not even be the best treatment for every patient. Our main goal and the driving force behind the Charlie 2 trial is to discover new and more effective ways to treat peritoneal carcinomatosis, and importantly, to improve the quality of life for patients in this state of their disease. All right, so the targeted approach of intraperitoneal chemotherapy. With that being said, let's focus on that specialized local treatment called IP chemo or intraperitoneal chemotherapy. Instead of the drugs traveling through your bloodstream like a traditional systemic or IV chemotherapy to reach cancer cells, IP chemotherapy involves placing the anti-cancer medication directly inside the abdominal cavity. Think of it like a very targeted bath for cancer cells in that area, so within the abdominal pelvic cavity. This allows for a higher concentration of that drug where it's needed most, which can be more effective and may also reduce some of the whole body side effects often associated with traditional IV chemotherapy. All right. In the Charlie 2 trial, we are specifically comparing two innovative ways to deliver intraperitoneal chemotherapy. First, there's HIPEC, which is heated intraperitoneal chemotherapy. With HIPEC, a warm chemotherapy liquid that is concentrated is circulated throughout your abdominal cavity. The heat itself also helps to kill cancer cells and make the chemotherapy more effective. In this study, it is done laparoscopically for 90 minutes. The second method is PIPAC, or pressurized intraperitoneal aerosolized chemotherapy. In PIPAC, the chemotherapy drug is delivered in a very fine mist. It's pressurized. This mist helps the medication spread evenly across the peritoneal surfaces, and this method is also done laparoscopically, and it is for 30 minutes. Both of these are recognized methods, but their direct comparison is key to this study. Although both PIPAC and HIPEC are common clinical use, their safety, tolerability, and efficacy have not been previously been compared in a head-to-head fashion. It's important to know that both the HIPEC and PIPAC arms of this study use the same chemotherapy drug, which is mitomycin C. This means we are comparing the delivery methods of the drug, not two different drugs themselves. Mitomycin C is well-established chemotherapy medication that is specifically chosen because it can be delivered effectively directly into the abdominal cavity to target cancer cells locally. So why are we doing the Charlie 2 trial? Why is it so important? Right now, both HIPEC and PIPAC are considered accepted treatments for peritoneal carcinomatosis. However, they haven't been directly compared in a comprehensive way to see which one performs better for patients in certain circumstances. This means that doctors often have to make decisions based on limited evidence or on their own experience, which can lead to variations in care. This study changes that. It's designed as a head-to-head comparison, which means we're directly evaluating these two treatments side by side. And we're going to try to understand better which is safer and better tolerated. This involves looking at things like side effects, how quickly patients recover, and their overall comfort. We're also going to look at which is more effective at controlling the cancer and achieving the best possible outcome. And importantly, which offers the best overall value for patients, considering not just the clinical outcomes, but also the impact on your daily life and overall well-being. Now, let's focus on who can enter this study. This is the full list as it is shown in the protocol. And I'm not going to read through every single one. I'd like to summarize, and then I'm going to highlight a few. So to summarize them, the inclusion-exclusion criteria for the study are to ensure safety in selection. So adults with a reasonable performance status who are relatively healthy by certain blood work standards are considered. It also ensures that patients have had the opportunity to have standard of care chemotherapy and have been evaluated for possible surgical resection or even had it. The trial is for unresectable peritoneal carcinomatosis from various disease origins, including appendix cancer and colon cancer. All right, so I'd like to highlight 3 main points. The first being the patient cannot be a candidate for cytoreductive surgery. So each patient will be evaluated by 2 separate surgeons at the time of the first laparoscopy. Each surgeon will make an independent assessment of whether or not the patient is a candidate for cytoreductive surgery. And I want to define that a little bit. All right, I'd like to give you a visual of one of the tools surgical oncologists use to assist in determining surgical resectability. There are several factors that are considered, but this is one of the big ones used across the board. So first, the surgeon assesses the PCI, or your peritoneal cancer index score. The volume of disease is given a value between 0 to 39 based on size of the tumors and location. Then the surgeon makes an assessment. Can they obtain complete or optimal cytoreduction? So that's the CC score, or the completeness of cytoreduction. A CC of 1 to 0 in general is considered a complete or optimal cytoreduction. So with that being defined, it is important to note that there is no universal standard for determining surgical resectability. This can vary from surgeon to surgeon or across institutions. However, there are a few findings that are generally agreed upon. So for example, diffuse disease involving the small bowel, or a frozen abdomen from diffuse disease and scar, or again, the inability to obtain a complete cytoreduction. And that point is especially true in high-grade, high-volume disease. So please keep in mind that these determinations, they've been based on data and experience previously. When there is a high probability of early recurrence or progression of disease after cytoreduction, generally that's one of those warning signs that the patient may not be a good candidate for cytoreductive surgery. All right. Number 2, the trial is designed so that patients may remain on systemic chemotherapy while they're on the trial, as long as it's not an investigative drug. The trial requires a 2-week period off of that chemo or chemo regimen prior to each trial treatment. And then the patient may resume their chemo regimen about 1 week after the trial treatment. So in general, a patient could potentially receive 2 doses or 2 cycles of their systemic chemo in between each trial treatment. And then the third is contraindication to laparoscopic surgery. In this trial, both methods of delivering IP, intraperitoneal chemo, are performed laparoscopically or through small ports. So, and the diagnostic lap, the assessing of whether or not they're a surgical candidate, is done laparoscopically. So dense adhesions and diffuse scarring would prevent a laparoscopic surgery, as well as any active bowel obstructions. Multiple open abdominal surgeries can lead to dense adhesions and scar, preventing laparoscopic surgery. And then, with that being said, potential risks, side effects. There are some common ones, but they're usually temporary, including nausea, vomiting. I think this is inherent to general anesthesia. Short surgical procedures even can have this. Fatigue from going through surgery for cancer, you're on chemotherapy. I think this is a very common side effect to expect. Temporary discomfort at the surgical sites. Again, they are small, but they can hurt. And changes in blood counts. It can be common, again, usually temporary. The intraperitoneal chemotherapy, for the very majority of it, stays within the cavity, and very rare for it to become systemic, and can also contribute to bone marrow suppression. Some less common, more serious side effects: infection, bleeding, cosmetic defects, injury to surrounding structures. And you heard me say earlier is that sometimes after multiple abdominal surgeries and diffuse high volume disease, the abdominal cavity can become very scarred down, and organs that were previously free-flowing can be very stuck to other organs, the abdominal wall, and complications like bowel perforation when trying to enter laparoscopically can happen. Allergic reactions, uncommon, and then any changes in function to kidney and liver can happen, but less commonly. All right. Now, moving through, let's walk through what your journey in the Charlie 2 trial would look like step by step. First, we have the screening phase. This is where we gather all of your medical information, perform necessary tests, and confirm that you meet all the eligibility criteria we just discussed. This is to ensure that the study is safe and appropriate for you. This is done via video visit if needed. Next, if you're eligible and decide to join, you enter the enrollment and randomization phase. This is a crucial part of any clinical trial and is done in person. You'll be randomly assigned to receive either HIPEC or the PIPAC treatment. Think of it like a flip of the coin. Neither you nor the provider, the treating team, will choose which treatment you receive. This randomization is essential for ensuring that the results of the study are unbiased and truly reflect which treatment is better. For patients that are traveling, this can be done the day prior to the planned trial treatment to make it more convenient. And then after that comes the treatment phase. You would typically receive up to 3 treatments. Each treatment would be approximately 6 weeks apart and delivered through a minimally invasive laparoscopic procedure, which means smaller incisions and generally quicker recovery times compared to traditional open surgery. We expect about 1 to 2 overnight stays in the hospital. You are not required to stay in the area and may travel home after discharge. Once the 3 trial treatments are complete, there is a 4th trip to the OR for a final diagnostic laparoscopy to assess treatment response and a final consideration if the patient could possibly be considered for surgical resection. And then finally, throughout the treatment and after your treatments, there's a follow-up phase. We will monitor your health and progress very closely with regular checkups, blood tests, imaging like CT scans, MRI. This is all done as part of your standard of care and can be done remotely. This structured approach allows us to gather robust data while providing you with comprehensive care. Please note we have in-person clinics located at Allegheny General Hospital in Pittsburgh and West Penn Hospital in Pittsburgh. The trial treatments itself only occur at West Penn Hospital. And to give you another visual, this is how the research team looks at the study flow. As you can see, I have all the study phases there. The treatments are listed as well as the follow-up. And then we designate what we're going to do at each of those times. And then one more visual, because I know the timeline is very important, especially for people who need to travel. This is a big part of your decision making. So remember, the screening can be done remotely. The enrollment must be done in person and can be conveniently timed to be the day before the start of the trial treatment. There are 3 treatments and they are roughly 6 weeks apart. We have a 15-day window of wiggle room, so we can coordinate with your local teams. That's definitely something that we incorporate into this study, especially many of you will be on chemotherapy, so we have to plan accordingly. So let's measure, what are we looking for? Our primary focus is always your safety and comfort. We will meticulously track any side effects you might experience, how often they occur, and how severe they are. We'll also examine factors like the length of your hospital stay after treatment and your need for pain medication, as they directly relate to your comfort and tolerability of the treatment. This is crucial for understanding the patient experience. Next, we'll assess cancer response. This involves using standard tools like blood tests, including tumor markers, and imaging scans like your CT and MRI to see how your cancer is reacting to the treatment. During the treatments themselves, we also obtain biopsies so that we're looking at the tissue and also the fluid within the abdomen. We're assessing that as well. And then we'll be looking at whether the treatment potentially makes you a candidate for definitive surgery down the line, if it's appropriate. A very important aspect is your quality of life. We believe that how you feel is just as important as the clinical measures. You'll be asked to complete surveys like the SF20 health survey, which is to help us understand how your physical, mental, and social well-being is impacted by the treatment. And your feedback is going to be very valuable here. And there we go. So the SF20 health survey is a list of 20 questions and takes about 3 minutes to complete. It provides the patient's assessment of their health across 6 domains. I provided a snapshot of the first 5 questions here. Once we have the results of the surveys, we can compile that data into a visual. So that's what this looks like, a visual representation of the patient's health across those 6 domains. So once this has data, it'll be very colorful and have different shapes. And then finally, we also evaluate the overall value of each treatment. This involves looking at the total cost of care associated with each approach, helping us understand the broader picture of resources and benefits. All right, and what it means to be part of a clinical trial. Your safety and well-being is definitely the #1 commitment. So your health and safety is a priority and is monitored throughout the study. Any side effects or adverse events or complications that you experience are timely or treated in a timely fashion. You have a dedicated medical team as well as a research team that help manage all aspects of your cancer treatment. And then there's governing oversight bodies that make sure that we're doing our best by you and protect your privacy and your rights. They help with that. We follow all the HIPAA guidelines. At any time during the study, you do have the right to withdraw. This is voluntary. Even though you say yes one day, you can definitely say no the next. And then we have a very rigorous informed consent process for this. Please note there are no reimbursement funds. All testing and treatments are considered standard of care and are billed to the patient's insurance company. This means if you have copays and a deductible, then the patient is responsible for those payments, in addition to any needed travel and lodging expenses. With that being said, we do have very resourceful nurse navigators, and they can screen for any available financial aid. So that wraps up what I want to say about the trial. The next slide can be considered graphic. So if seeing real images of tumor is triggering for anybody, I just ask if you want, you can look away for just a moment. But I know sometimes providing a very real visual of peritoneal disease can be impactful, and it can help understand the disease process and the treatment options that we're talking about. Not to mention define why this disease can be so hard to treat. All right, so this is a couple of photos of one of our patients who does have appendix cancer with high-grade, high-volume disease and is not a candidate for cytoreductive surgery. And earlier today, I figured out how to use a laser. I was pretty proud of this. So as you can see here, this is a port. So this is what it looks like on the inside when you place a port. And then this space in between, this is the inside of your abdominal wall. Down below are the organs. This is called pneumoperitoneum. This is that part that I was saying is important to perform these 2 methods, HIPEC and PIPAC laparoscopically. We need to be able to obtain this. There's many times that these organs, intestines, the omentum, are stuck to the abdominal wall. And that's why we can't get in. But as you can see, all of this is diffuse disease. This white is plaque-like tumors. You can also see it on the intra-abdominal viscera here. You can see it along the bowel, why this makes it so difficult to say that this patient is not a surgical candidate. You can't live without your small intestine. Sections of it can be removed, but not when it's diffuse throughout. And then these lower pictures, you can see not only is there diffuse disease, this tumor plaquing and studding, there's also ascites. So thank you everyone for your time. Thank you ACPMP for the platform to spread information about this trial. Personally, I find this study important because I want to see more treatment options for patients with peritoneal disease. I mean, ideally, we would have a cure or prevention, like full stop, no buts about that. I must say, though, I am encouraged to see teams of oncologists working on different strategies to treat this disease process. There are more novel things coming out all the time. So, for patients in attendance with this disease process, utilizing resources like ECPMP can be a vital tool in navigating this disease process.
Okay, thank you. I had to be moved out of the back room into the front to start the Q&A, but thank you very much, PA Altpeter and Dr. Wagner, for your time tonight and for this clinical trial, first and foremost, and then for the presentation to kind of unpack all of this. We've got some great questions through the Q&A function as you were presenting. And as you mentioned, we also have got some pre-submit questions. So I will say we're trying to focus tonight's Q&A on this clinical trial and on the presentation about it. As PA Altpeter mentioned, she didn't brag, but she has done a phenomenal job of taking dozens and dozens of questions that we got pre-submit and editing her presentation to try to address those. So that's super, super helpful. We're not going to be talking, though, about, of course, specific cases seeking specific medical opinions. You've got two great experts here to do that, but this is not the proper forum. I will say from personal experience, working with both Dr. Wagner and PA Altpeter, they are extremely responsive about when they get inquiries to reach out about potential exploratory private one-on-one consults. So that's the route for specific medical advice. Okay, so with all that, let's jump into some questions. I was tracking them as they were coming in, trying to look for where maybe the pre-submits might dovetail with some of what's coming in live so we can be efficient. I do see a lot of questions, no surprise, about eligibility and possibly a little bit of confusion perhaps within the appendix cancer patient community. So one, just really, we have people clarifying that you're not eligible if you are a candidate for cytoreductive surgery. So if you're a candidate for cytoreductive surgery, there's other options out there. You would not be eligible for the clinical trial. But some people seem to think you also can't be eligible for HIPEC to participate in this trial. And the whole point here in this trial, correct, is you're randomizing, you're assigning people, some to HIPEC and some to PIPAC. So it's fine, is that right? I mean,
Yeah.
If you're eligible for HIPEC, that's okay, just not cytoreductive surgery.
Let me tackle that, Deborah, because I see the questions as well. And I think it's helpful just to start with, when we are designing clinical trials for patients really with any disease, we are thinking about a particular patient in our mind or patients who we are trying to develop options for. For patients that are eligible for cytoreduction and HIPEC, or cytoreduction with or without HIPEC, our preference is to do so, because that is generally speaking going to be associated with the best long-term results. So there are exceptions to every rule. Sometimes we give patients HIPEC laparoscopically in a palliative setting, et cetera. But for the purposes of the clinical trial, are different than would we give this treatment to a patient with X, Y, and Z scenario clinically, perhaps on an individual basis. But in a clinical trial, we are trying to create a uniform comparison of patients who fit into a particular box so that we can control as many variables as possible with such a heterogeneous and diverse disease as this. So it's not so much to say that we would not consider these treatments for patients outside the clinical trial criteria. It's just that if we are doing a clinical trial, we have to keep the comparison groups as even as possible. So I think that's just something for everyone to know. We consider either one of these treatments to be standard of care or accepted therapies for individual patients. The clinical trial is being designed to answer a question. And for that purpose, that's a different purpose than what would I do for Mrs. Jones, who showed up in my office and, needed help with a particular situation. So maybe that clarifies the difference between would you consider this treatment for a patient, such and such and such a patient, versus who can be treated in this way on a protocol where there are strict comparison criteria. Right. So,
right.
Yeah.
Right.
Yeah. So the whole flavor of questions that are coming in about, well, I have had chemo, or chemo isn't part of a treatment plan for my kind of cancer, et cetera.
Mm-hmm.
That doesn't mean you can't get treated. It just means that the clinical trial wasn't designed for that specific question. And since we're talking about the clinical trial tonight, that's what the criteria are for the trial. We wouldn't be able to compare, for instance, the person with disseminated low-grade true pseudomyxoma from Lammen versus a patient. That patient can't really get a laparoscopy. If we can do a debulking, we need to do a debulking in that scenario. But that's not a scenario where we're going to be able to do a laparoscopy, get a wide open view, and treat the patient with intraperitoneal chemotherapy. That's not the question that the clinical trial is designed to address. Does not mean you couldn't be treated, but that's an individual personalized discussion, as you said, not really a question about the clinical trial.
Right.
So hopefully that clarifies things.
Okay. No, that's all very, very helpful, because as you see, there are a lot of questions about kind of the nuances with eligibility versus as a matter of treatment.
Right. Yes.
But you mentioned open and laparoscopic, so that's another question that we got for PIPAC. And again, I think Dr. Wagner, that's a nice tee up, because we have to keep thinking about the questions and the answers in the lens of we're focused on this clinical trial versus are you talking about as a matter of practice? So the question was, does PIPAC require full open or laparoscopic? And so for this trial, the answer is
we are doing minimally invasive surgery in this trial. If a patient is not eligible, if we can't get laparoscopy done, then we can't enroll that patient on the trial, because we are comparing laparoscopic HIPEC to PIPAC, which is always laparoscopic. So we are only able to compare patients head to head if they can have a laparoscopy. If you are not eligible for a laparoscopy, it doesn't mean that we wouldn't treat you. It doesn't mean that we wouldn't see you. We just can't enroll you on a clinical trial and compare head to head against a minimally invasive intervention. Those aren't comparable arms, and we wouldn't be able to rely on that data. Plus, we could randomize you, because if you're having an open surgery, you can't have PIPAC. So then we're just back in the category of the past decades of care where patients, are sort of compared in a single arm scenario where, HIPEC is given and there isn't really a comparison on it.
right. And then people are fighting about it years and years later.
Yeah, so Deborah, can I add just one point
please,
of clarity as well?
Absolutely. You chime in. Your
I'm sure you see this too, is that a lot of patients refer to the cytoreductive surgery as the HIPEC surgery. So I debated whether or not adding that too, but I didn't want to muddy the waters even further. So for everyone listening, I know it's common in the community to refer to the mother of all surgeries as the HIPEC surgery. But truly, it's cytoreduction. That's why I highlighted that definition of cytoreduction and how we assess it and how we define it and how we obtain it. The meat, right, the core of the surgery surgery is cytoreduction, painstakingly removing every visible tumor. Then you can plus minus HIPEC. So I know sometimes we call it the HIPEC surgery, and that's where a lot of this confusion lies, but it's truly the cytoreduction.
That's such an important clarification. Thank you, because I hear that a lot, or people will say CRS, meaning CRS plus HIPEC, or so to understand there are two components to the procedure, the cytoreductive surgical component, where you're removing tumor, and then follow up with the administration of the perfusion agent. So I think that is important, and that might be some of the genesis for the confusion about eligibility with CR, if you're eligible for CRS, I think that's a big part of that confusion. In addition to the complexities of clinical trial, answering questions versus clinical practice that Dr. Wagner had gone through. Great.
One other repetitive question that seems to be there is about our choice of mitomycin. So just to tackle that entire family of questions, you will never win or lose an argument about which chemotherapy to use in this context, simply because there's data all over the place. So we did not feel like we could use two different drug regimens in the arms and compare the techniques. We felt that we needed, at the end of the day, to be comparing apples to apples. Now, different surgeons, different centers have very strong feelings about drug regimens, and I understand that. There's a whole lifetime of literature to comb through there. For the most part, what we do in our center with HIPEC is almost always mitomycin. There are scenarios where we use platinum-based drugs for specific types of cancer, like mesothelioma or GYN malignancies, or some GI malignancies. But by and large, just looking at our database and our past, 5 years of being very busy, 90+% of our HIPECs have been done with mitomycin. So that is what it is. And so for the comparison arm, we did not want to use a different drug or a multi-drug regimen and start to introduce even more variables to something as complicated as this already is. So there's no perfect answer here. I think if we learn from this trial that these two methods of delivering chemotherapy are essentially equivalent, and or one of them is faster, better, safer, better tolerated by patients, et cetera, or more efficient to deliver, then we can start from that point and start to compare different drug regimens. But just picking one out of the data that's out there from single arm studies, there's no way to know where to start. So I felt, for this study, that there are enough variables here that we don't need to introduce additional ones by mixing and matching the drugs based on very basically low reliability evidence. So that's sort of the starting point that we're at. I wish we had better guidance on that, but we simply don't. So to keep it as a head-to-head comparison and really a fair comparison of two delivery modalities, again, emphasizing the patient side of this, which is where the quality of life, cost of care, indices, length of stay, amount of pain medicine used, all of that matters. And so then once we get that ironed out, then we can talk about which drugs are the best drugs to use in the next clinical trial beyond this. Just to tidy up a few of these other questions, this is essentially, I would consider this a phase 2 trial, a randomized phase 2 trial. That's what I would say. There's a couple questions about, is this phase 1 or phase 2? It's not phase 1. Mitomycin's been around for God knows how many years. HIPEC has been around for many years, and PIPAC has been around for many years. So we're not really doing a phase 1 study here. This is really a comparison of two established treatments. I would call it phase 2.
You want to answer the one about when enrollment begins, when the trial begins?
Already begun. So we've already treated several patients on protocol. I see questions about if I've had a previous cytoreductive surgery, am I eligible? Yes, you are. That would not ineligibilize you. If you have had so much surgery and treatment in the past that we cannot do a laparoscopy, that can be a barrier, but that's not about having previous treatment. It's really just about the feasibility of delivering the treatment in the study, which requires a laparoscopy. And then same thing with previous clinical trials, those don't make you ineligible. We need a washout period. So if you finished a clinical trial yesterday, we need to wait a little bit before we try something new, but not a long time necessarily. And then we are not trying to replace systemic therapy. So if you are on systemic therapy, we have to sort of turn it off around the times of our procedures. But by and large, we're essentially expecting that patients have already been on systemic therapy much of the time, unless they have lamin, which is not what this trial is really about. Nevertheless, patients that are on systemic therapy in the background, we really want to keep that going as much as possible. In other words, this is considered to be basically bidirectional. There's a systemic therapy treatment going on in the background, and we're really trying to see if we can make a difference on top of that with the procedures that we're delivering for intraperitoneal therapy.
And Dr. Wagner, I see a question about sites. So where is this clinical trial taking place? Is it there in Pittsburgh?
Yes.
Are there other sites elsewhere in the country, or?
This is a single center study. There's no reason why it couldn't be a multi-center study, but it's very hard to get it started in one center. So we started with that. And it's not that we couldn't consider opening it at other centers, but it would just that would require investigators at those centers really being motivated to do the background work to get it off the ground.
And then how long do you, and I know this is always tough with clinical trials, but how long do you imagine this trial will go on? I guess you're accruing to what, 200 patients? So how long do you think people will be able to be enrolled before it's capped? I don't know if you can disclose where you are in that. But then two, once the trial is active, how long do you anticipate it being before you have data, and that question goes so far as to say, and publicly available information through publications?
Yeah, so we'll accrue, I'm guessing, several patients a month at least, certainly off to a very rapid start, but I can't tell yet whether that's just a big burst of initial activity or whether it will sustain. So, if we accrue, let's say a couple patients a month, 3 or 4 patients a month, let's say one a week, that is a reasonable pace for our center. That's 50 a year, so it could take 4 years to accrue, and basically another year or 2 for analysis. It's not a long-term efficacy study, so we don't need a long period of time. And even by the time we would close the study, we would have a mountain of data already based on the patients as they come through. I expect that we will be delivering publicly, presenting interim results along the way. And many of these outcomes are almost immediately available. It doesn't take long to figure out how big the hospital bill was. That goes out there pretty timely with those. So we can get that information pretty quickly. There's a lot of translational research happening in the background. That will take some time. In other words, what happens in the tumors before and after the treatment, that's that's a whole other side of the research team here. That will probably be the last thing that comes out of this, but that has the potential to, obviously answer deeper scientific questions about how effective these therapies are. One of our endpoints, which I would consider exploratory because it's highly subjective and highly variable, but how often are we able to convert a patient from ineligible for cytoreductive surgery to eligible? And I would not put that out there as a primary endpoint just because scientifically the validity of that would be questionable because, again, it's subjective. And we try to have 2 surgeons both independently assessing the patient with kind of a blank slate and doing due diligence to say that yes, this is not operable. But if after the end of 3 treatments and the systemic chemotherapy that's going in parallel, we feel that it's worth trying after the 3rd treatment, then we would explore the patient and give it a shot, in that sense. And we will tally those numbers. And if it just turns out that we find that one of these treatment arms is more effective than the other in creating that opportunity, that will certainly be an interesting finding, but that would have to be validated in a subsequent trial more prospectively, and definitely in a multi-institutional manner, so that you would reduce some of that subjectivity by getting other surgeons involved. So that's about that. So the timing, in other words, that's a long-winded answer to your very simple question about how long until we know the outcomes. But there are different kinds of outcomes here, and they will come in as time goes by. So we'll know more about the quality of life, cost, pain medication requirements, things like that will be published on an interim basis. And we'll know the answer to those questions fairly early in the process. Some of these deeper questions and more scientific questions will be years in the making.
Okay. And so along those lines about when information will be available, we've got this question in the pre-submit, and then again tonight. How does that work in a clinical trial? How will it work here in terms of sharing data with other study centers that might also be doing a PIPAC related trial, or for whatever reason, other institutions that may have an interest? How is that data shared? Is it 2 separate trials, and the data, is shared through the literature and through the publication of interim results, or what? This trial, it looks like being asked about, is something out of the Henry Ford in Michigan. Might be completely different design. Yeah.
We in my world and this, as investigators, it is our duty to complete the study ethically, and part of the ethics of doing the study is to carry it through and publish the results, or at least present them, and that will be done for this trial. So we will share the results of this study with the scientific community and the general public as they become available. Now, other trials, I know that other centers are doing PIPAC, but that does not mean that it's being done in a trial or on a protocol where there's a commitment to do it systematically and to record the outcomes systematically and to present the systematic outcomes across all patients. So unfortunately, what often happens is that centers begin new treatments without really measuring or doing it systematically, and or without publishing the results across the board. In other words, and I'm not singling out any center or any treatment. I'm just simply saying what happens in the medical world when new treatments become available. So that's sort of the whole genesis of this trial in the first place for us, is that we did not want to just simply start doing this treatment and learn nothing about it in the meantime. We want to learn from this. We want to learn about it, and we want other centers to learn as well. And the only way to do that is to do it systematically and in a disciplined manner, and then commit to publishing the results, whether you like them or not, whether they're good or bad, whether you are rooting for one team or the other. You still have to publish a fair accounting of the results. And so that's what we're doing. Now, what other centers are doing, I can't speak to. I don't really know whether they actually have trials or whether they're just starting programs and doing the treatments. That's a very different thing. So we were more than happy to share our experiences with any other institution that is starting a program or doing this treatment. But we cannot compare our results head to head with a different trial that has different criteria, and or a center that has no trial at all, and they're just starting to do the cases really on a case-by-case basis. So I hope that clarifies that, but that is a common misconception that, such and such of a hospital is doing this, they have a trial on this, But in reality, what they have done is start doing cases, which is fine, but that's not really a trial, and there's not really a protocol involved, and it's not necessarily a systematic and rigorous approach.
Yeah, that's another really important distinction that I did not want to introduce, but I appreciate that you did, because I felt like it wasn't our kind of purview. But the I don't want to say confusion, but it kind of is some confusion currently with some centers. Well, PIPAC, and I'm talking about in the US, PIPAC is, I think many people know, been used in some other countries, but PIPAC in the US is being used by some centers outside of the clinical trial, as you described, Dr. Wagner, case studies, and it's creating a lot of confusion. We get a lot of phone calls from patients referencing all of these PIPAC clinical trials, but it ends up that it's places that it's not on clinical trial. So do one of you just want to take a quick minute and explain, kind of, for those that just might not be thinking in those clear terms, about, like, kind of repeat a little bit about what PA Altpeter was trying to lay out at the beginning, like what is a clinical trial? It poses a scientific question, and just kind of how that's different from best practice, I think, is a level set that might be helpful.
Yeah, I mean, PIPAC has been around for a long time. HIPEC has been around for a long time. There's a study documenting something like 5,000 cases of PIPAC, mostly done in Europe. It started in the United States, or it sort of made its way to the United States more recently. And so you're seeing phase 1 or early phase trials out of the United States over the past 5 years or so, but it's not like it hasn't been done elsewhere. So it's not that new. What is new is more and more centers in the US are offering it as an alternative. But if we just start doing it and we don't measure it, we will never know whether it does anything different, better, worse. We will never know the answer to these questions. It will just catch on. And then it's hard to reel that back in once the perception is that this has become the standard of care. So I will be thrilled to learn that PIPAC is better than HIPEC, or that HIPEC is better than PIPAC, or that they basically both achieve the same thing for cancer purposes, but one of them is cheaper, or one of them is faster, or one of them is preferred by patients. All of that would be useful, actionable information that we can measure, and then we can say, we know the answer to this. Without a clinical trial, we will just have 100,000 anecdotes about, I did PIPAC and this is how it went. Oh, I did it over here and this is how it went. And oh no, but I do HIPEC and this is how mine went. And then you just have a bunch of people telling stories about how it went when they did a certain procedure, but they do not have we don't have the data to compare it head to head. So that's where a clinical trial comes in, as opposed to just start doing it and then try to figure it out after the fact. If you do that, you end up with a mess, and it sometimes is a mess that you can never clean up. So I felt it was important in the US, as this becomes more popular. Now is the time to do the trial. If we don't do it now, it will become too late. It will just become too late because too many centers will be doing it with too many different criteria. The questions will never be asked, the questions will never be answered, and then we will just have a pile of single center series, all done in a different way, and we'll just never know. We'll just never know if one's better than the other or not.
And giving payers an excuse to be difficult for patients. But this having good, rigorous data should be very helpful to at least be able to confirm or deny and see what's going on. There are a lot of questions about eligibility depending. Does that depend on where in the body the appendiceal cancer has metastasized? So, for example, if someone has metastases to the lung, like, is there a specific preclusion for you can't have metastases in these certain organs, or metastases must be limited to the abdominal cavity, or does it depend?
So first and foremost, I know this is ACPMP, so I want to just say that this is not just limited to appendiceal cancer. We are stratifying based on cancer type. So I'll just back up a little bit further. We have a very active peritoneal surface program. Probably 60% or so of what we do, I would say here, at least 50%, probably closer to 60 or two-thirds is appendix cancer, a lot of colorectal cancer, and then a whole bunch of other things that are small slices of the pie: gastric cancer, ovarian cancer, sarcoma sometimes, small bowel cancer, neuroendocrine tumors, et cetera, et cetera. So we are stratifying our patients by the type of cancer that they have. So we will have a whole bunch of patients with appendix cancer on this study. We will have a good number of patients with colorectal cancer, and then we're just going to have a bunch of other just sort of small numbers of different kinds of cancer. And the way that we keep the study arms comparable is by something we call stratification. So rather than just randomizing every single patient, heads, tails, heads, tails, heads, tails, we have a pile of heads and tails that are assigned to appendix cancers in advance. So the appendix cancers are done heads, tails, heads, tails, heads, tails. Separately, the colorectal cancers are done heads, tails, heads, tails, heads, tails. And then same thing for sort of all the other cancers. That way we don't end up with, by some freak accident, we end up with all of our appendix cancers in the PIPAC arm and all of the colorectal cancers in the other arm, and then you can't compare the two arms. So that's called stratification, and we are stratifying by appendix, colorectal, and everything else. So 3 strata. So that's first of all. Secondly, this is focused on patients with peritoneal surface malignancy, or at least peritoneal dominant disease. Now, there's always going to be a patient with or many patients with questionable tiny lung nodules, or one spot in the liver, or et cetera, where we, under standard operating procedures, we would think outside the box and consider on a case-by-case basis. So as far as, Shannon, correct me if I'm wrong, but our exclusion criteria give us a little leeway there. I don't think we formally exclude patients on that basis, do we?
That is correct. Yeah, I was trying to answer some of the Q&As.
Right. Now,
exactly what you said.
We have patients who come in and they have a metastatic disease to the lungs, or a pleural effusion, or a lot of liver mets, or something like that. We can talk about whether treatment for them makes sense and what that would be on an individualized basis, but that would not be a situation that we would consider for the clinical trial. There's just too much variability there. It's that gets it very hard to keep comparable. So that's kind of not what it's not going to help us answer the question if we treat those patients on protocol. That's a scenario where we go off protocol and decide what the best thing for that patient is individually.
Good. And thank you. I see, PA Altpeter, you're whipping through some of the written questions. Know that when you type the written, though, the person that asks a question can see it, but nobody else can. So if you see any, and sometimes that's great, but if you see any questions that you think would be good universally, feel free to just shout out. And
here, I'll summarize a couple that I answered.
Great. Okay, good.
Let's see. I do want to point out, someone asked about insurance. So the way we approach that is we go through the screening process, and if you are eligible and this is something you want to do, then we take the codes. There are something called CPT codes that we use in the operating room for this trial treatment, and we'll submit that to the insurance company to obtain authorization. I haven't had trouble yet, because again, like we said, this is all standard of care that we're doing, the blood work, the scans, even diagnostic laparoscopy. So that can all be submitted, get the authorization ahead of time, and if needed, if there's a denial, I can always do an appeal process. Now, I'm not guaranteeing that every single insurance company is going to say we're in network. Sometimes we're going to be out of network, and patients may or may not have out-of-network benefits.
That's great. Thank you.
I see a lot of questions about how to enroll or how to contact us. So is
Yeah.
there, we need to get your contact information out.
And we're going to provide right after this.
Yes.
Alyssa is going to send out to everyone, and she'll also include it when we post this recording. We can send out all the information, so we can put it through the Q&A button now if you all want.
Yeah,
but
please.
when Alyssa follows up, we're going to follow up with any questions that we didn't get time for and sort through those and see what can be answered. And we'll follow up your contact information as well. So
Deborah, if it's okay, I think the easiest way for patients, this might be an easy way to remember, is when you go on Google and you go to Allegheny Health Network, there's something called the Hope Line that'll come right up when you go onto our website. And that's a great way to put in your information, and you can directly request Dr. Wagner and I and the clinical trial. So in case you get kind of lost, can't find our phone number, our email, go right to Google, AHN Hope Line, and that's a real direct way that you'll get that support.
Great. And Alyssa, please put that too in the follow-up. That's great to know. AHN Hope Line.
So
okay.
I'm seeing a lot of, and I also, just before people start to fade away, I want to thank Shannon. I am extremely fortunate to have Shannon as my clinical partner, but also, in the context of doing research together. So thank you so much for such a great patient-facing presentation. It's obviously, there's that. There's also the side of this, presenting it to the scientific community, but presenting it to patients and advocates and caregivers is a special skill. So thank you. So I see lots of heart emojis.
Yeah.
All right.
Shannon's fantastic. We all love her.
Yeah. Now there is a lot of questions about lamin and mucin, and
yes.
I want to sort of say that in general terms, we operate on lamin. Now there are scenarios where we can't operate for lamin, and those generally are also ineligible for laparoscopy at the same time. So it's not an exclusion criteria in any strict sense. There's going to be exceptions to the rule. Patients with I can think of scenarios where it would be part of what we're looking for this clinical trial. But at the end of the day, if a patient has lamin and they are operable, we recommend surgery for those patients. If they have diffuse mucinous disease, or sort of a classic pseudomyxoma scenario, and we can't really do laparoscopy under those circumstances. So it's just not the prototype of what we would be considering for this clinical trial. It doesn't mean we wouldn't treat you. It doesn't mean we wouldn't come up with a specific and individualized plan for a patient like that. But it's not on the question that we're answering. That's all. I hope that I know that's not a very satisfactory answer. It's just that I don't think anyone really believes that HIPEC or PIPAC, in the absence of cytoreduction for that particular clinical scenario, is going to be effective in any real sense. So we're trying whenever we can to operate on patients with that situation, and these treatments alone would not be expected to impact that much. On
lamin, and did you speak to the mucinous?
Just the questions about about lamin or diffuse mucinous disease, and we can't really do laparoscopy in that setting. And if we can operate, we're operating. We're going to do an open surgery under those circumstances most of the time. Right. We're really thinking about patients with miliary or higher grade disease that is a bit more on the other end of the spectrum, a little bit more invasive types of tumors, and less of the classic pseudomyxoma look.
Right. Good. And we got a couple questions from a couple different people about do we have any scientific knowledge, anything we know? Are you looking at in this trial anything to do with use of PIPAC as almost like a prophylactic, or as a preventative measure taken after having a hemicolectomy or other surgery, or are we just not even close to looking at it as a prophylactic yet?
I mean, I think I'm sure someone is talking about that. We haven't seen much of a signal when that's been tried with HIPEC for colorectal cancer, for instance. Whether there's an appetite to ask the same question, and it's actually been answered in fairly rigorous trials, certainly in comparison to most of the other scenarios where we use it. So that particular question has been fairly thoroughly investigated, in my opinion, without really any evidence of benefit in a prophylactic sense. So I wouldn't be shocked if you see someone out there design a trial of that nature. But in my personal opinion, our resources for research are better directed elsewhere. I just think that particular question, number one, is it's very hard to see a signal, and number two, it's been done fairly well already with HIPEC.
Great.
That's going to be a matter of opinion. You'll get different opinions from different surgeons on that. By all means, I don't speak for everyone, but that's just my personal take on it.
Were you going to say something, Peter?
Yeah, I know a lot of people on ACPMP are very well read. So the studies that Dr. Wagner was referring to are the HIPEC T4, the ColoPEC trial, right? And then what was the one in France? The prophylax. It was like prophylax. Yeah, that one. So like I said, I know a lot of you like to read about those. Those were the prophylactic HIPEC studies.
Well, you know what? That would be great. We can also put that. Hopefully, Alyssa, you're there with the pen, but if you wouldn't mind, we'll touch base with you after and get that list from you. And we can include that in our follow-up as well, so people could have that, if that's okay. Those 3 papers that you mentioned. That be okay? Okay. I had a question. Oh, Dr. Wagner, you had said this broadly earlier, but since we still have a few minutes, there's a question about Avastin, and if prior administration of Avastin would preclude someone from your trial. Would that be an example of one of the drugs that would just be a washout period for, or is that it depends, or is that a hard and fast exclusion?
Yeah, that was one of the ones I answered that disappeared. Sorry about that.
Oh, okay. No, I'm glad you answered that. That's great.
Yeah, technically, no, it is not exclusive, but it still follows the same regimen criteria that we need that 2 weeks off of systemic chemotherapy before each trial treatment, and then you can resume 1 week after. I've been giving like a subtext to Avastin though, because it does carry its own risks and possible side effects even on trial. So even though we're doing this laparoscopically minimally invasive, there's still risks that are associated with Avastin, with how it affects the bowels, how it affects wound healing. So it's just something that I like to have open discussions with patients. So technically, no, you don't have to stop it, but it is something that I just like to have one-on-one conversation with each patient if they're on it.
Great. And then, back to the question about where, if someone wants to enroll, where they would go. Are there sites, or is it a single site, or the multi-sites? It sounds like the site is AHN. And so you just want to clarify, though, for folks that might not know what that means, you don't have to actually live in Pittsburgh. It's just that you will have to be in Pittsburgh for the trial. But it will be open to anyone that meets the eligibility criteria without regard to geographic location. Or no?
Yeah, I'll give you a little insight is that the couple of patients that we've already done, none of them lived in Pennsylvania.
Yeah.
So it is definitely possible. I understand and will be sensitive to the fact that not everybody has those financial resources and those abilities to do that. But we do have a robust team and we can work with people to try and navigate that, how that will look and how we can make it possible. Dr. Wagner and I think we're particularly good at providing courtesy visits. So that first initial screening, we can do video visits with patients. It is again a courtesy visit. We don't charge the insurance companies. It is a video visit that we can set up with patients anywhere in the country and sometimes outside of the United States.
Typically, what Shannon's getting at is we consider them informational visits. They're not really official patient encounters. We don't provide medical care over the internet. We do follow up with patients over the internet that we have operated on, but up until the time that patients arrive in the state of Pennsylvania, by law, we're just private citizens having a chat about their situation. Now, we do try very hard not to have patients make travel plans until we're fairly confident that they're going to be eligible. Now, and so there is a final step, as we talked about, where we're in the operating room with a laparoscope and we have to verify. But if we are skeptical that we can get a laparoscopy done, we're going to be very transparent about that with the patient. We don't want them to be traveling at their expense and going through all of that only to be told that they're not eligible if we could have predicted that before they made the trip. So that's one thing that you kind of can often predict whether it's going to be possible or not, whether they're going to be operable or not. So that's really not very different from what we do with standard of care, though, frankly, which happens a lot, where we have patients that we're talking to and they're deciding whether to come for standard surgery, and we really have to try to navigate with them how likely it is to work out before they commit to the logistical and financial burden of traveling.
Yeah. And then we have a question, and some of these questions, so as Alyssa said, we're going to try to bucket up the questions that we don't get to and see which ones we might be able to answer working with our presenters here. But there was a question about, given that there are different cohorts to the trial, including the appendiceal, but other subsets of patients with other types of cancers, what happens if there's a patient that it's kind of an unidentified site of origin, it's suspected to be appendiceal, but nobody's been able to figure that out? That's like a very specific question.
Yeah, we don't need to know. I mean, we would randomize a patient based on what we think is happening, and if we found out later that it turns out that it was colorectal and not appendiceal, or vice versa, whatever the case might be, that's not really going to trip us up to. It's not going to happen that often, and that's not going to be a barrier. We do need to know that a patient's got cancer. Obviously, we don't want to be getting in there and finding out that this is endometriosis or some benign disease or something of that nature. But if it turns out that it was a different kind of cancer than we thought, that's not going to break the trial.
Okay, good. And then this is maybe a little more of a historical, philosophical question, but we have a couple minutes. It looks like you guys have done a remarkable job running through a lot of these. Shannon, please keep skimming. You're doing a great job banging them out. But why is it that PIPAC here in the US, at least the standard of care, seems to be lagging behind some of the other countries?
PIPAC, is it?
PIPAC, yes, PIPAC.
Yeah, that's a good question. I mean, I think there's several layers to that. The European centers are very centralized, and they can do very big clinical trials there on fairly focused questions better than we do them here. And there's, it is what it is. I think if our system was built the same way, then we probably would have the same ability to to get clinical trials done, but it's very hard to get multi-center trials done in the US, and especially in this disease site, and to accrue to them. And a lot of it just comes down to patients having autonomy and choice, and they can go where they want, and they go, they decide what they want and they go get it. In Europe, it's not like that. So, I mean, I think you have to consider that, yes, it's great that this technology was developed and studied. I admire the European system for their rigor and their organization and getting clinical trials done. I mean, we're nowhere near where they are in that regard. However, the patients that were treated in that manner might not have been permitted to seek other treatments that they might have wanted. So you just never know what was on the other side of that. In other words, in the US, maybe a patient would have been offered, you can have a cytoreductive surgery or you can have IP treatment, and they might have elected for cytoreductive surgery, whereas in Europe they might have been told that they're not eligible, or that's not an option, and that was their only option. So I don't know that we're behind. We'll find out. Time will tell whether it's that we're behind or not. It has taken off there. It's an appealing idea, the aerosolization. I will say that getting it off the ground in an operating room is a little bit of a uphill climb. There's a lot of occupational safety issues that you can imagine with aerosolizing the chemotherapy and the potential for exposure on healthcare staff, et cetera. To be honest with you, it's way cleaner and way cleaner, and I think lower risk than HIPEC to the OR team. During a HIPEC, there's this liquid chemotherapy that's sort of splashing around. It's a little messy sometimes. With PIPAC, it's very streamlined. It's in a circuit. It really, as long as you set it up properly, there's no mess at all. And so I think at the end of the day, if PIPAC had been invented first, we wouldn't ever be talking about HIPEC because it's messy. But that's not the way it is. So to get it off the ground and to get the right, you've got to start with the OR staff, nursing teams, administrative teams, anesthesia, et cetera, et cetera. So it's just, there's a logistical barrier to it, I think. And if we knew for certain that there was a lights out head-to-head benefit of this technique, I think we would have picked it up faster, which is where the trial comes in. If we learn something about PIPAC in this trial, that it is better, faster, safer, cheaper, more tolerated, whatever the case might be, then I think that will make a big dent, and people will just say, oh, okay, well, it's worth it. It's worth it to deal with my anesthesiologist and deal with my OR nursing staff and deal with the occupational safety requirements, et cetera, because it's better for patients. We just don't know, and we'll never know until we study it. So that's sort of the kind of a great, ironically, a great question to end on, because it sort of takes us back to why we're doing the trial in the first place.
Good. Yeah, we're pretty much out of time. We're right up on our 8:30 mark. So let me just ask Dr. Wagner or PA Altpeter, do you have any closing thoughts before we kick it back to Alyssa to close us out?
We're here to talk to patients individually about their scenarios if they wish. I think that's easily done anytime. And again, I couldn't do any of this without Shannon, so I want to give one more shout out to her about that. And a lot of friends that we see that we know near and dear to us on the chat. So good night to all of you. And we have the ACT coming up next, next month? Yeah, 2 weeks from now. So a lot of other centers will be hearing about this protocol in the upcoming meetings. The SSO, the Surg-Onc meetings in the US, the two biggest meetings are back to back in February and March. And so the word will get out about the trial. I'm sure it'll incite some debate. I'm sure that on a scientific level, there will be a healthy amount of cafeteria, old-fashioned food fight about the selection of the drugs and why we didn't do other regimens or whatever the case might be, but that's okay. We've survived those before.
Mhm.
Great. PA Altpeter, did you have any closing thoughts? Or,
Oh, just grateful. Thank you for the opportunity and thank you for everyone joining. I really do
thank
appreciate
you.
it.
Thank you for all that you do. And okay, Ms. Alyssa Strackline, go ahead and close us out.
Right. Thank you, Deborah, and thank you again, Dr. Wagner and PAL Peter. We're so grateful for your time, and thank you to everyone who joined us tonight. As a reminder, we'll share responses to selected unanswered live questions on our Zoom event page and at acpmp.org at a later date. Also, if you think of additional questions, our friends at the Appendicure group will be hosting a follow-up live Q&A on Thursday, February 19th at 7 p.m. So check that out. And thanks again to our presenters and everyone here tonight. Have a great night and weekend and stay warm if you're on the East Coast. Thanks,
Thank you, everybody.
Bye-bye.